I'm delighted that you are here in this training for Oooram 2.0. And this course is basically critical airway management and training. And this is actually very important. And I want to put things into context. We've been doing this formally since 2012, since the VA Central decided that we had to basically optimize airway management because there was a lot of adverse events, specifically when dealing with out of the OR airway management. There were mismanagement and adverse events, serious as is always the case when we do adverse events in airway management. So this is why we're here. It's basically trying to get a group of people that have give our veterans a fighting chance in order to survive, and that there are other things to have adverse events from, but not from airway management. Um, if you want to do any further reading, or if you want to download this image, you can actually download this QR code, and you'll be able to do that by doing that, and you will have any further list of all the references used today. I do have a relationship to Declare. I used to be from Bayer Advisory Board. It's in the past 12 months, but it now basically dissolved. And I am a consultant for Medtronic, but no conflict of interest here. All the images that you are seeing here are my own. I own the rights for them, or I have taken them on my own. There's only 2 of them that I actually requested permission, and you can see the permission request on this slide. So everything here is original. And what we're going to talk about today is basically that type of kind of intersection between kind of resuscitation and airway management, which is always the case where when we're dealing with out of the OR airway management. Think about it. You don't do out of the OR airway management because the patient is healthy or because you basically have time. It's usually in the most precarious of circumstances, usually at the end of life of some person, and or maybe even doing resuscitation maneuvers, and that's when it usually happens. So it's not abnormal that we actually have to consider that we need to be our best in order to have adequate consequences. And when we're dealing with out of the OR, is we deal with wide spectrum of patients, different age groups, etc., and different locations as well. It's completely different to have, for example, a trauma hospital has certain kind of indications, or basically in the ICU. If you're in the medical ICU, there are certain sets of problems that present themselves commonly, versus in the surgical ICU is different. But we also have to consider as well that we just went over basically this pandemic from COVID, and that really made a difference about it. So it's not just the ICU that I want to mention. I also want to mention that the emergency department is also a common place where we do this type of interventions. Now, the truth of the matter is that basically out of the OR airway exposes several vulnerabilities in terms of individuals, in terms of groups or teams, and in terms of institutions. And just going to put it into an example, and this is kind of the prototypical type of case that we see ourselves in the hospital. The most common reason we intervene in the airway is due to pulmonary complications, specifically in our basically elevated age of our patients in the third age, or basically in the latter stages of their lives. And usually smokers, etc., we do see that pulmonary complications are the most common reason why we have to intervene. So this was basically a local case. This is a patient that came into the emergency department with respiratory failure. When he was admitted, they took this blood gas. You can see the levels here. You can see he was retaining CO2 severely. And they basically, the team started working up for CO2, COPD exacerbation. They did all the kinds of things that usually are done by in the emergency department, etc., and then almost 3 hours or 2.5 hours later, they do another blood gas to see how he's doing, and you can see that that patient is not doing well. So at that point, obviously, even though maybe it was decided earlier on that that patient needs, there's no other way to try to avoid it. This patient needs mechanical intubation, mechanical ventilation, and obviously in order to do that, you have to basically perform an intubation. So the team prepares for it. And as they described it, they tried direct laryngoscopy 2 times and they could not see well. So at that point, they bring a video laryngoscope, and they also tried 2 times, and they cannot actually get the tube adequately. They rescue the patient with a supraglottic device, and at that point, a third provider becomes available, and he says that he is able to do it. He tries again video laryngoscope with a hyperangulated blade. He tries it twice. He says in the last attempt, he's able to see the glottic opening and goes ahead and places the tube. Unfortunately, respiratory therapy starts saying that they're having problems ventilating the patient, and therefore it's considered that there's something going on specifically with the cough, because they cannot achieve the tidal volumes that they want. The team then decides 2 hours later to perform a tube exchange, which is not easy to do, not easy to perform. And once the crisis is over, a couple hours later, you can see the latest blood gases. This is the lowest pH that I have seen in a medical patient and the highest CO2 that I have seen as well. This is the kind of similar thing that you will be facing when you're dealing with this airway emergencies in the hospital. And this is what we called, or what we've actually learned to call, the physiological and situational difficult airway. That is, when the chips are down, you do not have control of the circumstances or the locations or the time of day. This case could have happened, for all we know, on a Sunday evening during a holiday, for example. And that's actually the case. So those are patients that are really seriously deteriorated, and the circumstances are such that things are not in our favor, or if we don't do things correctly, the things will have a bad outcome. Now, I already alluded to that the most common cases that we do is for pulmonary reasons, but there are other reasons why we commonly intervene the airway, and one that we have seen recently about of is basically due to neurological dysfunction, that is for CNS protection, which is another reason. And the reason why things have changed is I've noticed a lot of change since the use of non-invasive ventilation and high-flow nasal oxygen has really decreased the number of intubations that we perform emergently, which is actually very good. Another reason that we have seen is that with the onset of the rapid response teams, we are able to identify patients before they deteriorate, and so therefore we don't see as many emergencies as we used to see. But that means that the ones we see are really in extremis and are really need for adequate care in order to have a good outcome. Now, there's also another thing that we have to consider that is called the physiological and situational difficult airway. But I also add another level to that, which is the ergonomic difficult airway. As you can see in that image over there, you can see, for example, how the operating room is perfectly designed for this. Is the lighting is perfect, the bed is narrow, we can shift it up or down, head down, whatever is it that you need. Versus you can see in the center of the image, that's an ICU bed of our institution, and you can see that there's a metallic kind of bar there in the middle where one will be standing. So it makes it very hard to deal with patient to even reach the patient. And you can see the pumps on the right, etc. They all make it very tough. And even further, the one on the right, the image from the emergency department, what you see there behind the patient is a wall. So getting behind that wall, behind the patient, to adequately position ourselves to get basically be able to reach the patient is very difficult. So think about those things. But if those things were not only difficult, our patients are also very difficult. And this is kind of, I don't make this fun. I'm not trying to make any fun of anyone, but this is what we deal with, is people that are basically obese, perhaps have facial hair, are smokers, are drinkers. And this is what we call the physiologically challenging patients. And the truth of the matter, what you need to remember is that when we look at series of patients in the same scenario, about 25% of them have rapid or profound desaturation during maneuvers of airway management. We failed our first pass in about 30% of them. And basically in a quarter of them, we have post-intubation complications. That is, the tooth might go in adequately, but we still have a complication. So these are patients that are extremely sick. one of the most common side effects that we see is aspiration pneumonia. And of course, that's the reason why is because obviously the difference between elective procedures or airway management or elective anesthesia for that matter and emergency is the fact that we basically in surgery, for the most part, if it's not emergent, our patients are fasted. Your patients, on the other hand, will not be fasted. It's not uncommon, for example, that they actually have a meal before they come into the emergency room or something like that. So aspiration is still a very common problem, and it can be quite severe. We recently had a patient that succumbed after a massive aspiration and basically required ECMO for about 30 days, and he was not able to make it. So this is actually something to consider. Now, in terms of severity, there are a couple of things to remember. This is perhaps the most used classification system in the world. It's called the Macocha score. I do not know how they came up with the name, but basically, anytime you're dealing with a patient that has a high Mallampati, therefore the M, basically that has sleep apnea or cervical spine issues or limited mouth opening or is in a coma, that is neurologic dysfunction, is hypoxemic, or basically is not performed in the anesthesia context, that is in the surgical context, then it's considered basically high risk. And basically the numeral goes from 0 to 12, and it's basically 0 if your patient is Macocha. 0 is easy, but the higher the score, the harder it is to basically adequately handle the airway, and it's going to be a challenge for anybody. So a high Macocha score basically is kind of a index of complication and severity and difficulty, and this is something to keep in mind. Now, when we look about adverse events when we deal with the airway, I think there's four major areas that we can group them in many different, but there's kind of four major areas. It is basically when we fail to optimize care and oxygenation, when we don't do a good job when we're taking care of the airway, when we do excessive number of intubation attempts. That's been, for example, our patient, an index patient, had that problem. When we fail to prepare or adequate implement frontal neck access, and that's FONA, and we'll be using that term here is frontal neck access, or when we actually deal with non-technical issues that impair our adequate group performance, even our individual performance as well. So those are the major areas that we have seen deficits, and we're going to try to overcome them with training and with discussions. And what we all want and what the VA wants is for us to have what's called adequate standard of care. That is a group of personnel that has known and great tools and resources, and that's just not just implements, but also human resources that have adequate medications and have adequate monitoring to, as I said before, and I'm going to continue to say it, is to give our patients a fighting chance so they don't have adverse events when we handle the airway. So that's what we're here for in a nutshell. And key stakeholders about this whole program and plans is us, everybody here, you and I. Everybody that's surrounding it, or respiratory therapists, nurses, etc. If we have an adequate group of people that can take care of it, that are knowledgeable, then we will be able to give adequate care and we'll be able to do a good job doing that. This is what we are the liveware, our equipment is considered the hardware, and our plans is considered the software. But I think the most important aspect is, and the biggest and most important tool that we have is the human aspect, and that's why we spend so much time and effort, and that's why you, for example, are spending so much time in furthering your academic formation, etc., etc., because we are the most important aspect of airway care. Now, we do have to talk about the hardware and the essential resources that when we deal with airway. And I call it the essential resources is always the same. And I hope you take this so you can remember this. And what do I mean by that? Well, SAME stands for suction, for airway tools, and those include obviously tubes, oxygen masks, AMBU equipment, etc. video laryngoscopes, bougies, supraglottic airways, anything that is an instrument that we're going to be able to use. The M stands for medications. Medications are important to consider. And the E stands for obviously monitor and end-tidal CO2. So those are always the things that we are going to basically, when we get called in, we are going to assemble right next to our patients. And fortunately, we have been working on ergonomics of such for a long time, and we're getting better. We don't always do the right work, but we can always improve and do it better. And that's why there's been great amount of effort trying to get our airway cards and our uh, airway bag when we transport, because we go to different places of the hospital to respond or to basically deal with these airways emergencies. And when we have there in that bag or in that card, it's what's going to make us be able to take care of the patients adequately. So equipment is a very important thing to consider. I recommend everybody, every time that you're on call or something, to make sure that you have access to your equipment, that somebody has checked it, that is up to date, that nobody has opened the lock, for example, that has taken something that is crucial, like for example, a small tube, or that, for example, if you're using electrical equipment that has been plugged in and charged, etc., etc. Those are things that should not be taken for granted, because at some time or another, they have actually happened. We need to talk about basic and advanced airway management maneuvers, and that's what we're going to be doing in the next couple of slides. And I know that the whole point is that we talk about it so then we can start practicing here on the mannequins. And obviously, thinking about the mannequins are good for certain things, but they're not similar to adults or humans, I'm sorry, in many aspects. So we have to basically think about that. We have to take what we do with the mannequins with a grain of salt. So, as I alluded to, one of the problems or pitfalls has been a failure to optimize care and oxygenation. And we're going to be focusing on oxygenation, because why do I say that? In the past, there's been too much emphasis on intubation per se, and that's not the goal, even though intubation is a very good and effective way of doing it. But the problem is it is risky and it's difficult, and sometimes it's impossible. So what we need to concentrate on is in oxygenation, and that's what we're going to be doing. We're going to be talking about basic skills, and specifically the one that comes to mind is face mask ventilation, and basically the most important thing, and I think the take-home message, is that every time we're dealing with the patient, we have to always attempt to position the patient as good as possible, if that is possible, because sometimes the patient may be trapped inside a vehicle, for example, or I have done it in patient showers, which is difficult, or the patient has cervical spine or a cervical collar, whatever it is. But as long as you can, you have to basically provide what's called a sniffing position, or the head and neck elevated position. As you can see here, we can do it either with blankets or in the operating room if you have one of those fancy beds that you can actually elevate the head and kind of extend the head. And the idea is that you pass a straight line between the earlobe and the sternum. If that's the case, you've adequately positioned the head for all your maneuvers of airway management. So that's the first thing. It's crucial. If you don't do it, then, or if you can't do it for some reason, you're really taxing yourself for future maneuvers. So I want you to think about this. This is a core maneuver that we always should try to master. Obviously, we start with one person technique for ventilation, and this is the normal grip, the C grip that everybody knows about. And just a reminder, there are a few people that are very hard to mask ventilate, and those are the you can see from top left to right, the edentulous, or the patient with large tongue, or the patient with facial hair, or the patient that's obese. Those are notoriously difficult to mask ventilate, and you might need to actually elevate or escalate your approach. And for that, we basically do, instead of one person, a two-person technique in which you keep your mask keeping a tight seal and another person bags the patient. It's very common to be done, for example, during periods of ACLS, et cetera, et cetera. And if you can, or if you're still having difficulty, which you may have, you're able to use one of the um, basically tools that we have, which are the oral and nasal airways. Remember, an oral airway cannot be used on an awake patient, otherwise you basically induced a gag and perhaps vomit and aspiration. And can you think about times when you cannot use a nasal airway? I can give you a clue here. For example, I don't even take it to the cath lab because those patients have usually received thrombolytics, and I don't want to create epistaxis. But anytime you've had any distortion of the anatomy, either surgical or basically from trauma, you don't want to be placing anything inside the nose that you can exacerbate things further. So keep those things in mind. Now, very important is the concept that we've had for, I think, almost a decade. And I think that's also another important take-home message that I want to give you, is that we're trying to increase, when we do this, the safe apnea time. The patient might be apneic, or we may making the patient apneic when we're doing the maneuvers or airway management. So what we're trying to do with these maneuvers is to increase the safety window so we can actually make it so the patient is adequately saturated when we're doing this. It's what's called the safe apnea type, or safer apnea time. And we have several different modalities, and I've actually basically circled the ones you can see that the oral aperture is open and therefore can be used. You have traditional methods of oxygen delivery, and you have fancier ones, which is, for example, the non-invasive ventilation, nasal positive pressure ventilation, one that we use commonly, which is a supernova. And then top right, you can also see one that is also being taken up like a storm in the whole world, which is high flow nasal oxygen. And it is very unusual that you see a patient that is not already in oxygen, specifically the ones that come into the hospital with respiratory issues. So if you have one of those patients, or if you have one of those modalities, keep the oxygen going while you're actually trying to control the airway. Believe it or not, you can even place the mask on top of it. Obviously, be careful that you don't over insufflate the stomach. But the whole point is that this gives you more time and gives you better safety when you're dealing with the apnea episodes that we create invariably. Now, we need to talk about advanced maneuvers. I consider masking kind of a basic core maneuver, usually one that somebody else is doing by the time you reach the emergency setting. And they're calling you because you are supposed to be doing advanced airway maneuvers. And the first one that I want to talk about is an alternative device or a rescue device that's called the supraglottic device. And in this hospital, we've actually turned to use a second generation. It's called the iGel. It's a cuffless system and also is an aid for intubation. Although I must tell you that the intubation is an advanced maneuver. It's an advanced technique that you need to practice and rehearse and be kind of certified before you actually undertake it, because it's not an easy procedure. But the advantage of this device is that it's easy to do. It can be done with minimal training. This is where basically the tip of the supraglottic ends up. This is a model of the larynx, of course. And you have it. It comes in different sizes, and it basically you select your size depends on the patient weight, and it's a blind placement, and that's, you can see from the center, that's where the tip ends up, and it basically provides gastric decompression, and if there's regurgitation, it can go through that gastric opening. And one of the major advantages and one of the major reasons that we use it is during ACLS maneuvers, because it does not require interruption of CPR, which is an essential component of resuscitation. Of course, everybody is always concerned because it's a temporizing maneuver. It can be predisposed to aspiration. And unlike what the American Heart says, even the VA manual says, it does require some practice. So I do recommend that when you're doing your practical, that you actually try it on in the operating room with a real patient so you can get used to it, because it's not as easy as it looks. If it was easy, then people that do airway on every day would not have the same deal of respect that we have for the supraglottic airway. So don't believe what they say that is anybody can do it. Maybe it is true in certain scenarios, but also you require a little bit of practice when you're using these devices. As I already alluded to, this particular device is a great conduit for intubation, and there's two methods of doing it. Both that we recommend is with optical guidance, specifically the flexible fiber optic guidance, and one is with the entry catheter to your left, and then the other one is using the tube as a conduit. But I put there on the right kind of a serpent icon, and what I mean by that is, yes, you do need fiber optic guidance, and you do need to practice this technique often before you try it on a real patient, because there's potential for adverse events of happening, and this is what's considered an advanced technique. So if you're going to or think about using it, or you're not going to call another provider as a consult during emergencies, and you want to do it yourself, do practice it and do get certified before you actually do this on your own. We have to talk about laryngoscopy and intubation, which happens to be one of the most important and timely airway maneuvers that we've always done. And there's two methods of doing it: the direct laryngoscopy, which has been developed since the last century. The two blades that we commonly use, the direct and indirect, were released in the 1940s. And the new kid on the block, which is indirect laryngoscopy, which is a little bit newer, is about 2 decades old, and it's been taken up by a storm because it has several advantages over direct laryngoscopy. Now, I must tell you here, and I'm going to place an asterisk here and kind of pause here, because there's a lot of emphasis in the VA initiative for airway management to use video laryngoscopes. I think that you should be using the one you feel most comfortable with. And I do think, of course, there's an advantage to video laryngoscopes, but I can also not fault you if you prefer the direct laryngoscope. Our job is to make you good with the video laryngoscope, because it's going to make you perhaps become more accurate, better first time success, etc., etc. But the experience of the provider is crucial for the performance of either or. Obviously, I am a person that advocates as indirect laryngoscopy or video laryngoscopy as first choice devices, and we're fortunate that we're an institution and we are a group of institutions that has basically taken this up by a storm, and we have it available in every site and intubation. But once again, your experience is crucial. Now, laryngoscopy and tube placement are complex procedures. Laryngoscopy is actually, you can divide it into 4 different steps: exposure of the larynx, advancement of the tube, placement, mid-trachea of the tube, and securement of the tube. If you fail in any or more than one of these modalities, then the chances are you're not going to have a successful laryngoscopy and intubation. The more things you have difficulty with, the more chances the tube will end up in the wrong place. But you always have to consider that when we do the practical, we're going to be practicing kind of good maneuvers, good kind of habits to have, so you can become. Now, the types of video laryngoscopes that we have basically what's called the monitor tower, which we have. Fortunately, we have plenty here in our system. We also have the portable, and we also have the guided channel devices. And what's more important perhaps than that is the geometry of the blade. Now, I do want you to get comfortable and to get experience with both types of blades, that is the hyperangulated blades and the regular Mac blades, because there's actually kind of difference. Obviously, the hyperangulated blade gives you better exposure, but that comes at the expense of making the advancement of the tube a little bit more difficult most of the time. I am personally, and this is, I'm going to throw in my contamination here, is I'm an advocate for Mac blades as first choice devices, because I find it that especially people that don't do this often have less difficulty advancing the tube. However, if you place the Mac blade and you're not having a good view, of course, reach for the hyperangulated blade, and there's nothing wrong with it. It's just that entry of the tube requires a little bit more finesse and a little bit more practice, and there's more prone also to having pharyngeal oropharyngeal trauma, and we have seen that in our hospital. So keep that in mind. Obviously, our indirect view is going to be impaired in cases, and you can see there a patient with a small bowel obstruction, and so therefore anytime you have aspiration or you have a gastric contents or you have blood in the airway, your view is going to be affected. Fortunately as well, especially the MAC blades can be used both for direct and indirect, and that's actually very important and a very important feature of these devices. But you are going to have instances in which your view is going to be impaired, even with the use of video laryngoscope. Let's take a 10-minute break here. Invariably, one of the things that as providers and airway providers we have to do is to determine whether our procedure has been effective or not, and whether, for example, if you're intubating, whether the tube ended up in the respiratory tract and not in the esophagus. And you might think that this is strange that I'm telling you this, but one of the most still common and devastating consequences of airway management is the fact that tubes unfortunately get still placed in the esophagus and they're not detected on time or detected at all. And invariably that will lead to hypoxic encephalopathy and brain and patient's death. Still happens nowadays. The other thing to consider is that end-tidal CO2 monitoring is also a very important monitor to guide us in resuscitative maneuvers, etc., etc. So invariably, when we deal with airway management, we have to be detecting CO2. That must be used in variable. It's very important to look at the pattern and cycling of the waveform capnography, looking at the amplitude, which has to be greater than 10 millimeters of mercury, and also it has to be sustained. And sustained means that it's greater than 6 breaths. So there are 3 modalities to actually consider the measurement of CO2. One of them, and the most important or gold standard, is the waveform capnography. On second place is capnometry, that is, there's no waveform but a numerical value, less preferred. And last, and if only used when the other 2 are not available, are the colorimetric responses to it. It's so important that in Great Britain, and that has been adopted throughout the world, the campaign of no trace, wrong place is being actually taking place right now, meaning that if you have no trace after doing your airway maneuvers, masking or placing a supraglottic airway, etc., if you do not have a trace, then immediately you have to consider that you are in the wrong place. I want you to take this by heart and take it as a kind of the lessons learned. Of course, might be reasons why initially you may have CO2, but the tube may end up in the wrong place. For example, if the patient just had a carbonated beverage, and for example, doing procedures of endoscopy and insufflation, it's not uncommon. You may initially get that, but unsustained type of waveform. In case the patient has had a prolonged face mask and you've actually have swallowed, or the patient has swallowed some air, then you may get it initially, but then basically dissipates with time. Same thing by bystander rescue breathing. And when the tube is basically placed above the trachea, you may still get it, but it's, again, the waveform is abnormal and it will not be sustained. There might be multitude of reasons why the patient may not have CO2, and invariably people tend to go with the differential diagnosis, either technical and equipment issues and clinical issues, for example, severe airway obstruction, bronchospasm, pneumothorax, cardiac arrest, and bronchopleural fistula. The same thing, faulty monitor, disconnection, warming, calibration, etc. What I want you to take home by message is that it is, if you have no waveform, is not any of those other things, is esophageal intubation until proven otherwise. And the reason for that is that if you basically do it and you do not detect it on time, your patient is going to end up with irreversible brain damage and perhaps death. Now, we need to talk about the last core maneuver that we need to talk about is the invasive approach to airway management. Something that already alluded to at the beginning. We're going to refer to FONA, or frontal neck access. And as I alluded to, remember, is one of the major failures of modern airway management happens to be when we fail to prepare or implement FONA in an adequate fashion or time. And that's why we need to talk about it. And that's why it's the last ditch effort, the ultimate rescue when other non invasive or semi invasive maneuvers have failed. So the question that comes to mind is which approach or kit should we take? There are so many. And that basically speaks to the fact that when there are too many things or methods of doing it, you know that none of them work out great. And this is actually the case with frontal neck access. But basically, since around 2016, I believe, there's been a paradigm shift throughout the world, and we've actually converted initially to percutaneous approach to what's called the the scalpel cric technique for percutaneous or um, invasive cricothyroidotomy. And that's the one we're recommending here in this course, and the VA has adopted as well, because it seems to be the most effective and efficient way of actually doing that. Doesn't mean it is the best. And I'm pretty sure we get a lot of resistance, specifically from ENT surgeons and all that. But that's not what we're here for to discuss. We're here to discuss cricothyroidotomy in the context of rescue failed non-invasive methods of airway management, when basically is the last ditch effort to deal with the patient. Let's talk a little bit about the cricoid membrane, because it's actually something that is very elusive. It's actually quite small. Initially, some of the anatomy books used to say that it was around 1 centimeter, and you can actually feel it in most patients. But more recently, especially with newer methods, it actually be seen that it's less than 1 centimeter, and I'm talking about in adults as well. One method to locate it, and I want everybody to be doing it at the same time, is to try to locate three specific landmarks. The first one is suprasternal notch. The second one is the most prominent cartilage, which is the thyroid. And in between those two is where you will find the cricothyroid membrane. Those are the external landmarks, and everybody should be doing it at the same time that I'm talking here to you. So the first step, and that actually one of the most common and recommended maneuvers that we should do when we're pre-oping or basically evaluating a patient, is to perform what's called the laryngeal handshake, which is basically we try to feel for the cricothyroid membrane of our patients, or basically touch on that to locate it ahead of time. Obviously, we're talking about when we have time. But there's other modalities, and it's specifically being recommended by many if you have time, of course, and if you have not in an emergency situation, is to locate the cricothyroid membrane via ultrasound guidance. The next step that comes is afterwards, once you've actually located or think that you know where it is you make a vertical incision to the skin and subcutaneous tissues. Once you've opened that, then you make a horizontal incision in the cricothyroid membrane. Then you introduce the bougie, and through the bougie, you do what's called the railroad of the endotracheal tube. And that's the cric bougie technique that is being recommended nowadays. Now, doesn't mean that it's easy or that it's very robust literature that supports that this is the best way to do it. No, we're going with best case scenario of something that is invariably done very infrequently, specifically in the non-trauma literature, for the general practitioners, and for the non-trauma hospitals or non-military hospitals. But it seems to be that it's a lot more efficient than what we used to use, which was a guide wire technique with the traditional Melker cricothyroidotomy set. So I know this is a lot, and I want you to do me a favor. I want you to close your eyes and breathe deeply for about 15 seconds and relax. Take what I just told you. Try to feel your membrane. Try to feel your suprasternal notch, your thyroid cartilage. Try to locate where your membrane should be, and try to imagine you're doing this procedure. And I think that's very important because we're going to get to practice on the mannequin next. We need to talk about something else, which is rapid sequence intubation pharmacology, or what rapid sequence induction as well is called in anesthesia. And it's very important to consider the optimal use of pharmacological resources allows airway managers to maximize the potential and increase the successful management of advanced airway procedures, included intubation. This is something that is basically being adopted worldwide, and fortunately, after the COVID pandemic, even the most reluctant providers, which happens to be certain subgroup of providers that were not using muscle relaxants routinely, are now using it as well because they have seen the advantage of using them for airway management. So the RSI has 4 major components, and actually 3, and the 4th one is basically kind of support. And obviously it has to deal with pre-medication in case, for example, you have time and the patient, for example, has high ICP. You want to limit the sympathetic response that you get with the administration or basically with the intubation itself. The administration of sedative, followed immediately by muscle relaxant, and of course you have to consider after the intubation takes place. So those are the 4 major components. And what I want you to think about is like an arc. And basically the first arc is the pre-medication, second part sedation, third part muscle relaxation, and fourth part the post procedure itself. And what we have to do is consider that's called the FLOP. And FLOP stands for fluids, and that's what you see first there. To basically, most of the time you get a hypotensive response, so you want to administer fluids ahead of time. Then you want to, specifically in patients that you want to limit the sympathetic response that you get. And you want to limit the ill effects of the medications that we give you. For example, give a bolus of lidocaine or a bolus of drug opioids such as fentanyl. You can avoid them if you don't have time or in cases that basically you're dealing with cardiac arrest. But those are the things that we normally do. And importantly, the P stands for pressors, because unfortunately we still create a lot of hypotension when we do our administration of our drugs. So we always have to be ready to provide pressor support in case hypotension occurs. And it's important to consider that because invariably you will deal with greater morbidity and mortality if your patient becomes recalcitrant hypotension or persistent hypotensive, or the levels of blood pressure seriously drop below normal values. So you always have to consider that you have to do that. Now, here's a table, and I'm not going to spend too much time on it because it has basically the drug, the type of drug, and in green you have the induction agents or sedatives, as you like to call them. Then second one is in blue, you have the muscle relaxation. The third, the vasopressors, and the fourth is basically the sedatives, or basically adjuncts that you give sometimes when you do rapid sequence intubation. And you also have the normal dose and the dose for usually patients that are very sick, which is usually the cases that we are involved with, and how it's supplied, etc., etc. The most important drug that I think you have to remember is the use of etomidate as your sedation agent. And as muscle relaxant, you have 2 choices. Basically, we're down to 2 choices, either succinylcholine or rocuronium. There are advantages and disadvantages to both, and I think you need to know them both. Basically, the succinylcholine has rapid onset and short duration, but is associated with the release of potassium, especially in patients that have neurological issues or have been bedridden. That's concerning because it can lead to fatal arrhythmias. And it also associated with bradycardia and the dreadful malignant hyperthermia. On the other hand, rocuronium is a dose-dependent, basically rapid onset. It has long duration. It can be associated with anaphylaxis, and basically, if you use it, you need to provide some sort of sedation afterwards, or else your patient will basically be awake but yet cannot move themselves. And it can also be associated with residual weakness. So you have to know them both. If you ask me which one I prefer, specifically if I don't know the patient and I go into a crisis situation and I don't know much about the patient or the history or anything, I prefer to use rocuronium because I'm not sure if I'm dealing with a patient that has one of the predisposing factors to having fatal arrhythmias or something like that if I use succinylcholine. This is basically the same table as we had before, but summarized. And I think you need to learn 3 drugs. And the fourth one, was in yellow, is basically the kind of something that you can omit if the patient is not an extremity, if it doesn't have a neurological problem or anything like that, which is the use, for example, of lidocaine. And the same thing here is basically the take-home message is basically if you know how to go from 1 to 10, is usually phenylephrine you give 1 cc. That's to support blood pressure in case the patient is hypotensive. Etomidate you give 5 to 10 cc's because that's 10 to 20 milligrams total dose. I've never given more than 20 milligrams in my life, to give you an idea, because I'm always concerned about hypertension. Rocuronium, you consider that the patient is roughly, for an adult, is 100 kilos, so you end up giving 10 cc's. And lidocaine, you end up giving 100 milligrams, which is 1 per kilo, so to speak, if the ideal body weight will be 100. So basically, you have to remember 1, 10, 10, and 10. And that's what the take-home message is. And the more you do this, the more you actually will get familiarized and become second nature to you. But this is the take-home message of the drugs. Important to consider, as I already alluded to, after the intubation takes place, always remember to have fluids in case your patient becomes hypertensive. Always sedate your patient afterwards, otherwise it's going to be terrible, and your patient actually may extubate themselves, which is actually not good. And so that's why you always have to provide sedatives afterwards. The question is, do you need a second break right now? We're going to omit this one and carry on and talk about non-technical factors. And it's important to consider that, as already alluded to, we are the liveware in this equation of variables that deal with airway management. We are the personnel issues, which are very, very important. And we always have to consider that we have issues about errors have been made because we have errors in situational awareness, or we make the wrong decision, or we basically do not work well with others, poor teamwork, poor communications, leadership and followers is not being made, or basically we're not dealing well with our stress and fatigue management. Those are issues that are human factors that, if are not taken care of, are not paid attention, can lead invariably to errors in airway management. So one of the most important things, and the ones we emphasize, and by the way, now that you've taken this course or seen this video, you now have become part of the team. We basically arrive at the scene and we compose and take care of an airway care team. We're part of it. And when we basically don't know anybody there, we call ourselves by our name as hey, I am so-and-so, I'm an expert I'm the intensivist, I'm the emergency on call, I'm anesthesia, whatever it is, and I'm here to take care of this patient's airway. And you basically assemble a team that ideally should have 3 or 4 people. One is a runner that is going to hand you equipment. The other one's in charge of equipment and IV access. First provider that's going to be in charge of the intubation itself, and leader that's going to be calling the shots, and it's going to be a backup person to the first provider. That's, for example, a team. Now, I will be in the ideal scenario. If you only have 3 people, you basically assign 2 roles to 1 person, etc., etc. You get my message. The whole thing is that we basically start working as a team, which is very, very important. A lot of emphasis since 2010 has been made to create what's called the airway bundles to decrease adverse events. That is, basically has been shown to one of the major factors for reducing adverse events and complications. In a particular study, the original study by De Jong from France, it showed that when you follow the protocol and you had kind of a same group of people using the same medications with the same devices, and doing it the same way every time, you had approximately 58% reduction in adverse events or basically errors in the management of the airway, which I think is very important, because when we start cutting corners or we forget or omit a step is when we start making errors. So by doing it the same way every time, you have less chance for that to happen. So I think creating airway bundles is actually very important. And we have to talk about plans. And unfortunately, we've come full circle to that, because unfortunately, we are not making good plans. We usually, when we talk about the average person, they start talking about devices. And I want to take you kind of one of those take home messages is that a tool is not a plan. We need to have plans and guidelines the same way a team organizes plays, et cetera, whether that's hockey, whether that's basketball or football, whatever it is. The huddle is important, and it's important to pre-brief if you have time, to then afterwards do a debrief as well to see what could have been done better and to come up with plans and guidelines as to how to do things better. Now, there's a bunch of airway guidelines throughout the world, but I consider them that they're very complicated, and they look to me a lot like a kind of a electrical circuitry, and we need some simplicity, specifically when we're dealing with airway emergencies. So I think, for example, I like the personal to think about airway as a pyramid, in which basically the first floor is what most people do. For example, in my case, will be my first attempt will be to perform laryngoscopy with video laryngoscopy. I personally use Mac as a first device for the majority of patients. The second attempt, if I failed, is going to be with a hyperangulated blade and a bougie. In that case, if I use a bougie, which is not common when I use video laryngoscope, the third step will be to rescue with a supraglottic device, and if everything else has failed, to perform frontal neck access. So to me, you can see there that simple is a four-step type of device or kind of plan, and it's easy to follow. There's one basically that is one aspect that is very important is when we're dealing with teams, and specifically when we have multidisciplinary teams or people don't know you or you arrive at the floor and nobody knows you, is to have a shared mental model of what's happening. And one of the things that has been advocated is the use of vortex approach. And in certain aspect, the vortex is good, but I don't think it's the panacea also of airway management, because it does leads a lot also undiscussed, for example, evaluation, et cetera, et cetera. But it's a very good way of doing it. And the vortex is basically, you see it right there, and it's been adopted throughout the world, and because it's actually is a good way to share mental image. And as you can see, the vortex is seen there looking from above to the left and looking from the side to the right. And what you're seeing there is that we have 4 different modalities to handle the airway. You have 3 semi-invasive, which is mask, supraglottic, and tube. And if those fail, then we have to go to surgical airway. And you see in it from the side that as soon as we start working and dealing with things, we start basically circling, and we can do it clockwise or counterclockwise. But the more we do, then the more chances are that we are losing time, number one, and that we're going to be less successful. One of the most important aspects of the vortex is that it recommends that we limit the number of attempts at each of the modalities, because as we alluded to before, the persistence is not that good, and if we continue doing the same thing over and over again, we do not get any better results. So what the vortex has taught us or has shown people is that you do another attempt, but you always try to basically make your attempt the most successful by, for example, improving the patient position. It might be the head position, it might be getting a new device, it might be making sure that you have you given, has it been enough time that you've given muscle relaxant or, for example, hypnotic agent? Is your suction adequate? Are you giving adequate oxygen? The whole point is that you try to optimize your next maneuver so that you have greater chance of being successful. And that's what it has become so accepted throughout the world. And I think great is a great thing, but I don't think it is also the panacea. Now, I have a question for you guys. Can you think of an example of good teamwork in airway management? I do. And it has to do with COVID. See, this is what we did in COVID, and basically this was all of us, and the world was basically going through this horrible period of time in which we had a contagious disease with via airborne spread, with severe respiratory involvement and high index of mortality, and the possibility of basically getting affected ourselves and also having patients that were profoundly hypoxemic and they dropped the saturation even further when we made them up or we tried to intubate him or something like that. So if you think about it, and perhaps you thought that the pyramid effect was kind of crazy, but was it? I'm going to show you what we did. Most protocols, if not all protocols of airway management that were published, showed that the first choice should be to handle the airway in somebody with COVID was the performance of rapid sequence intubation with video laryngoscopy. If you use a MAC blade and you failed, then you went to hyperangulated blade. If that failed, you went to third choice with the supraglottic, and then if that failed, you escalated to frontal neck access. So you can see there, this is basically kind of the pyramid approach that I already alluded to in perfect description and perfect scenario. You also wanted to limit the number of people that were close to the patient because you wanted to limit the potential for providers getting infected as well during the process of airway management. So this is a perfect scenario and perfect description of the plans, and simple plans, because if they're very complex, nobody's going to follow them. So that was very important. Now we're going to speak a little bit about real scenarios, things that we've seen happening often or that have had major impact in the way we handle the airway. And this is when we actually, at one point in 1 minute, we're relaxed, we're perhaps having a conversation with our group or a team, and all of a sudden we get a phone call and things are actually not well in some point of the hospital, patient or ICU or emergency medicine, or one of the wards is not doing well, and we have to invariably run. So I want you to remember our local case. Well, think about the patient that we started with, and remember it had required multiple attempts at intubation. It was 6 video laryngoscopy attempts, and then they also ruptured the cuff, or the cuff became malfunction, and they finally were able to intubate him, but had a pH of 6.9 or something like that. Now that patient gets extubated. And unfortunately, as is not uncommon, the patient now develops respiratory distress after getting extubated. The patient gets transported again to the critical care unit, and non-invasive ventilation is started and high flow nasal oxygen, et cetera, and it's determined that the patient has recurrent pneumonia, which is not uncommon to hear, and is not responding to non-invasive monitor. So invariably, that patients need to be intubated again. So the take-home message of this, and why I'm bringing this, is those patients should be taken care of, specifically not in an emergency fashion, because we've had time. This pneumonia did not happen overnight or all of a sudden. This has had time to develop after the period of extubation. And what I'm trying to teach you is that airway management care should be decided and should be as elective as possible, if at all possible. And what's important, and to the right of that slide, is the fact that then if you think that you require escalated approach, or you require an extra pair of hands, or a special tube, or a special device because this patient was already difficult, the time to do it is before the patient gets into extremis. You know he's going down, but he's not down yet. That's the time to intervene. And that's the take-home message here. Another very important aspect is that, and they were very wise, is they reviewed the chart and saw that the patient was difficult to intubate. So they were able to consult, for example, an ENT surgeon or an anesthesiologist to help them actually deal with this patient, because he's going to need instrumentation of the airway, and we know he's already difficult. One of the most common causes of difficulty is if the patient has already been difficult to intubate. So by reviewing the chart, review the intubation template that must be invariably filled, then we know ahead of time, and we can actually adapt and basically anticipate ill events from happening. Another event that happens often is ACLS. how do we take care of the airway during ACLS? Well, of course, we cannot plan because those things happen all of a sudden. But I think the most important thing is that we have an escalated approach. Usually basic maneuvers start with face mask ventilation, and we already talked about that, and those some maneuvers to actually making it better. Hopefully it should be done by experienced personnel with rescue equipment. And then the second best option is to provide advanced care, and we have two options. And placement of supraglottic airway should be your first option. Is usually performed after the second round of CPR. And the advantage of using supraglottic is you don't need to interrupt the cycling or the performance of the CPR, which is very important. The third choice is the possibility of placing an endotracheal tube, but that's usually reserved by highly skilled individuals and usually not in the when CPR is taking place, because it's very difficult to perform intubation and laryngoscopy when somebody's undergoing CPR. And it's usually reserved after ROSC is achieved. So the thing to remember is it's perfectly acceptable to rescue somebody with a supraglottic device. And then if the patient needs intubation in case ROSC is obtained, then to perform intubation or replace the supraglottic for endotracheal tube once the patient stabilizes. So that's common with ACLS. So I have this slide here for you to actually emphasize those things. Is the supraglottic requires lower skill, the tube requires higher skill, and the supraglottic has greater first pass success. The intubation has lower first pass success. The supraglottic requires no interruption of CPR. The intubation requires basically more time and CPR interruption, and we know how deleterious that is. And the supraglottic is an intermediate step until ROSC. Obviously, the tube or intubation is a definitive step, but is usually reserved after ROSC is obtained. Another common thing that we deal with, and we get about one case per month, roughly, is angioedema. This is one of our patients, of course, and the important thing to remember is that it's a stepwise approach. I think medical management is very important, and what we want to do is to limit the extent of edema and the compromise of the patient, specifically to make him, this is very stressful for both providers and for the patient as well. So you want to actually limit the ill effects of that. We have to provide early warning. That's why we start when the patient arrives to the hospital. We start the phone call early because we need to have specifically looking at the airway, the extent of the airway compromise and the extent of the edema by performing a fiber optic scan on them to look at the extent of the edema. What we're trying to do is obviously reaching that point in time when trying to perform RSI, because if RSI is very difficult in this patient population, and you have a very limited window. If you fail, then more than likely all other modalities are also going to fail, and you're eventually going to end up with a severe adverse event, if not a death patient. Now, I'm not saying that you should not perform RSI on patients with angioedema. What I'm saying is that that should be your last-ditch effort, because the patient should have an escalated approach, trying to avoid getting to that point in time when the patient needs RSI. If I can avoid it, the last commandment in the care of angioedema will be to perform RSI. I want to avoid it as much as possible. So this is what we do. The patient comes in and we start supplemental oxygen. We elevate the head of the bed to actually decrease the amount of edema. Obviously, medical management begins and all the anti-inflammatories, steroids, et cetera, all those things that you know how to do, then get done while we're basically supporting our patient. The next step is evaluation. Usually, evaluation is performed by an ENT to determine the extent of edema. Then this patient should be transported and placed in a monitor facility to make sure that they're responding adequately to care. And it's very important to establish expert consult early in case escalated approach is needed. So that's the take-home message with angioedema, which is very similar to basically patients with severe cervical spine pathology. You also want to, and we see that a lot, specifically post-op patients that undergo procedures in the cervical spine, And usually in the post-op period that we can have severe airway compromise afterwards. So those patients should be in a monitor setting when there's early warning signs in case of impending trouble. Early warning is important and immediately escalated approach. And what we're trying once again is to avoid getting into a point where RSI is needed. Not that RSI would not be needed or that you cannot do it, but the chances of being successful are small. So we're trying to actually reach the patient when the chances are better. And that is basically by doing early evaluation and looking at alternative approaches to airway management before the patient gets into extremis. Another group of patients that's important is the people that have surgically modified airways, that is laryngectomies or tracheostomies. And remember, by definition, about half of patients with fresh tracheostomies have some sort of problem. The problem may deal with, for example, dislodgement or cuff malfunctions or issues, obstruction of the trach, or bleeding. Those are commonly things that happen after a tracheostomy. I think one of the most important factors to determine is the timing and type and maturity of the procedure that has been made. Remember, you're going to be meeting a patient that has some form of surgical modified airway, but you don't know what it is. In case of tracheostomy, it's considered mature 7 days. At seven days after surgical tracheostomy, and some consider it a little bit longer. But after percutaneous approach, and we're doing more percutaneous approaches now, it doesn't reach maturity until after 10 days. And what's important is if the patient gets a dislodgement of a tracheostomy, don't try to place it in if it's not mature, because likelihood is you're going to end up with a false passage and you're going to create more problems than actually good. So what you need to do is to look for something else. It's important to consider that we're fortunate that this is the type of sign that the patient has, so you know what you're dealing with. And the reason why we have that is because we've had cases in which the only thing that we see is a hole in the trachea, and we don't know if it's a tracheostomy or a laryngectomy, and there are differences about them. And the main difference is obviously the aerodigestive continuity. If you have a tracheostomy, you can actually still intubate the patient from above if the patient is intubatable, of course. Remember, you may actually be doing a tracheostomy because the patient has difficult intubation, so always consider that in mind. But if the patient has a laryngectomy, there is no way you can actually approach in the oral axis. You're not going to be able to reach the trachea because there's no aerodigestive continuity. So it's very important to determine the type of procedure the patient is at and the maturity to determine what you're going to do. In general, and this is basically a stepwise approach, this is not for a particular problem, but a set of problems that I alluded to, the dislodgement, obstruction, cuff issues, and bleeding, is the first thing you do if they call you a problem with the patient with a surgical modified airway is you call for help. You look and listen to mouth and trachea. You establish if the patient is apneic, and if you do, you basically initiate CPR and start administer oxygen as much as you can. You have to occlude, obviously, the stoma, otherwise you're going to have a leak of oxygen. In case a patient you're suspecting obstruction of the trachea, you establish if the trachea is patent. If the trachea is mature, you may remove the valve, the inner tube, and attempt suction, but that's only if you feel comfortable doing it. Then if cuff is present, you must determine if, for example, the cuff is herniated and that's the reason you're not being able to ventilate. And last but not least, you remove and exchange the trach and laryngoscopy in case the patient needs it, but only if, once again, if your patient has a mature trach. If not, it's better to go, if the patient has an immature trach, to go from oral access, directly reintubation and passing the level of the tracheostomy, or administer oxygen any other way, because it's not possible to do so any other way. So again, this is very general, but this is what you need to basically individualize the problem that your patient might have. So I want to finish here saying that this is basically the out of the OR airway management chain of survival. And what we want to do is to have adequate personnel, which you are part of that. We have adequate resources, which we are about to see what resources we have. We perform basic and advanced care. And once again, we try to give our patients the best chance possible to not have adverse events when dealing with airway management. I want to thank you for your attention. I want to thank the VA for being so supportive to all our endeavors. We've been doing this for quite a long period of time, and hopefully we can do it for more. And luckily, one of the things that I always say is that it's not that we don't make mistakes, but what we try to do is not make the same mistake twice, which is actually more important. I want to finish here with some key references for those of you who want to read further about it. You have them right here. And thank you very much for your attention.